So, because of paucity of time, we'll start, I think, no? So I'm going to talk on management of coexisting cataract and glaucoma, no financial disclosures. So we all know that this is a very common disease because of the aging process. So how to manage this condition to promote the best visual outcome is the main important question which arises in everybody's mind. So the initial decision making is crucial in determining the type of intervention in these combined diseases. So approach to a patient with cataract and glaucoma, you have three approaches basically. You have a cataract extraction with IOL implantation alone, then you have a sequential surgery where trab is done followed by cataract surgery later on, and then you have the third option which is a combined cataract and glaucoma surgery. So first we should know what are the indications for cataract extraction alone. So the indication is that should be a visually disabling cataract with IOP under good control. There should be a mild glaucomatous damage, minimum visual field loss, one or two well-tolerated topical anti-glaucoma medication, and the patient should also be compliant with this anti-glaucoma medication. So these are the indications for cataract extraction alone. Now coming to the sequential surgery where trabeculotomy is done first or a glaucoma procedure is done first followed by cataract surgery. This is called a two-stage approach. The indications being when the glaucoma dominates the clinical picture, there is a significant optic nerve damage, there is an advanced visual field loss, there is an uncontrolled glaucoma despite maximum medical therapy, or cataract surgery can be done 4 to 6 months later once the filtering bleb is well established. So this is basically the indication for this two-stage procedure. Now, what are the indications for the combined surgery? In India, the most common indication for a combined surgery is economic issue. But what are the other indications? Failure to achieve target pressures by medications, issues related to compliance, adherence, and drug-induced side effects, borderline controlled IOP, disease progression, or advanced glaucomatous optic atrophy, despite maximum medical therapy, and uncontrolled glaucoma, but an urgent need to restore vision with two operations are not feasible. So combined surgery is the most common indication in our country because of the various reasons which I already mentioned in point 1 and point 2. So coming to the surgical considerations, first preoperative consideration is we should know whether the significant visual loss is due to the cataract or the glaucoma, because patient always expects a better vision. He thinks that the cataract surgery gives 6 by 6 and even with the glaucoma combined surgery or a glaucomatous surgery, he is going to restore vision. So proper counseling is a must after determining what is the main cause of visual loss, whether it is cataract or glaucoma. If it is glaucomatous, we have to counsel to the patient that this vision loss what is there is never going to regain back. So we are doing this procedure to retain whatever is left. Slit lamp examination should be done properly to look for any pseudo exfoliation, shallow AC, and if it is a myotic pupil, you should be prepared how you are going to deal with this myotic pupil. Fundus examination again to look out for the glaucomatous optic atrophy and also to look for any macular pathology which is going to give a poor visual prognosis. Coming to the operative considerations, you are all trained phacosurgeons or cataract surgeons, so you should be well versed with the devices or what are the things you are going to use to tackle this myotic pupil. Coming to viscoelastic, sodium hyaluronate is very important because it maintains the flat anterior capsule and it deepens the AC, and whenever you wash it out also it comes in one go. So sodium hyaluronate plays a very important role. Coming to the operative considerations, your access should be adequate size and IOL selection. You can use a PM or acrylic, but if there is no capsular support, AC IOL has to be avoided. You can implant an SFIOL, or I would still recommend an Iris Law better over an SFIOL because the amount of dissection with SFIOL is more, or you can go with the newer Yamanese technique or the newer techniques of SFIOL. Coming to the techniques, the cataract extraction after filtering surgery, cataract extraction should be positioned to maximize the bleb survival, which is very important. The incision site depends on the location of the filtering bleb. Usually the filtering blebs are located superiorly or superior-nasally, so temporal location is the ideal location. We should always do a slow motion phacoemulsification. We should not traumatize the bleb when you are doing the cataract surgery. So phaco with foldable is a choice of surgery, and most of the time we do come across the synicase. So synicolysis is a very important step to be done. Coming to the triple procedure, that is the combined surgery, you have the single site technique and the dual site technique. Single site, that is cataract surgery and the trab is done to the same site, usually it's the superior side. You can combine SICS or phaco with the trab. If it's a twin site, then usually that is the preferred because most of them are temporal phaco surgeons. So cataract is done through the temporal side and the trab is done to the superior side. Both of them are giving the IOP reduction which is there. It is not statistically significant. Only the thing is the surgical time required for the combined the twin site surgery is a bit more. So I'm going to show you simultaneous videos of these two combined surgeries. So coming to few important techniques, basically whenever you take the stay suture, whether you take a superior rectus bradal suture or the corneal stay suture, you make sure that you go in a one go, you don't have multiple punctures. Your stay sutures are very important. Every surgical step plays a pivotal role when you're performing the surgery. So once you have taken the stay suture, you always mark the conjunctival flap, do the subconjunctival dissection, identify the bleeders. Never do a rough never do blind cautery. Always try to identify the bleeders and give gentle cautery. The coagulation, the cautery power should not be more. always mark the scleral flap. If it is an SICS trap, I do mark at 6.5, and if it is a phaco trap, I do mark at 3.5. Marking of the conjunctiva and the sclera is very important because you should know what is the size of the flap you have created. You can create a triangular flap or a rectangular flap, whatever you are comfortable with. Again, choice of antimetaboloite which you are going to use. You can use the sponge or you can use a subconjunctival mitomycin before the start of the procedure. It is your preference, but make sure that whatever you use it, you could calculate the dose according to the need based of the patient. Making of the scleral flap is very, very important. You should try to lift the apex of the flap and just touch the cutting edge of the 15 number blade at the junction so that you get a nice uniform flap. And this flap will be of good size only if you not over cauterize it. If you over cauterize it or do a blind cautery, there will be shrinkage of the scleral flap. So when you have done the scleral flap, you will always see that the mismatch between the scleral bed and the scleral flap. That is because you have over cauterized the scleral tissue. So this is very, very important. Never over cauterize it. When coming to the SICS trap, the normal steps of SICS continue. And when you are doing a twin side phaco trap, now you shift. Once you have created the scleral flap, you shift temporally and do your normal cataract surgery. So for phaco trap, I would recommend a slow motion phaco, and for the SICS trap, all the steps continue. Now, important step, I'm just going to skip one of the videos so that because of paucity of time, coming straight to the trap techniques. So you can do the trabeculectomy either the internal ostium, you can prepare it either with 11 number blade and MVR, or the best would be a Kelly's punch. So Kelly's punch gives a very good control when you are doing that when you are preparing the internal ostium, because your chances of iris prolapse and AC shallowing is minimized because that gives a very good control. So you can make about 2-3 punches vertically and then 2 lateral. There are different patterns. You can have an L pattern of internal opening or the mushroom pattern of internal opening. So once you have done the internal opening, do a broad based peripheral areorectomy. Then coming to the closure of the scleral flap, this is very, very important. There are different techniques. You can put an apical intermittent suture, or you can put a single apical releasable suture, or you can put 2 releasable and 1 apical suture. So the technique of suturing is very important. I am showing you the technique of releasable suture in the SICS trap case. You first pass the suture into the clear cornea parallel to the limbus, and then from the clear cornea perpendicular to the limbus, and then into the scleral flap. 4 throws are taken, and these throws are passed out so that you get a horseshoe lace kind of suture technique, and whatever exposed part you withdraw it out and you can pull it and titrate it. So because of paucity of time, I'm just going to finish my talk. Thank you.